The contents of this podcast reflect the views and opinions of the host and do not constitute medical advice. Hello and welcome back to Long COVID MD. I'm your host, Dr. Zeest Khan, a licensed and board-certified physician navigating recovery from long COVID. Today is the last episode of Season 1 of the Long COVID MD podcast, and I want to thank you for joining me if you've been here from the beginning. I have a lot more in store coming up, and I'll talk more about that near the end of this episode, so stay tuned. Today I want to talk about my specialty, anesthesia, and how patients with long COVID might respond to anesthesia, both general anesthesia and local anesthesia. I have seen discussions and questions about anesthesia when you have long COVID on social media for quite some time. It often pops up. One of the first things I did when I started talking about my own condition was write an article for my colleagues at the California Society of Anesthesiologists about my experience with long COVID and the anesthetic implications of patients with long COVID. So I'll link that article in the show notes if you want to check it out. Today I'm going to summarize a little bit what to expect when you're having anesthesia and to sort of demystify how the many drugs that anesthesiologists use work on the human body. And since our bodies are a little modified right now with long COVID, we might respond a little differently. First, I want to talk about local anesthetics and in particular, visits to your dentist, because this is probably where you're going to experience as a patient the direct actions of a local anesthetic. A local anesthetic, one example is lidocaine, and it is the medication or one of the medications that is injected into usually your gum line by a dentist before a dental procedure to numb one or several teeth and the surrounding tissue that's going to be worked on. Local anesthetics are powerful, important, and overall very safe. But we've all experienced probably either directly or have heard a story where a dentist is working on us or a friend and suddenly you feel pain. You scream out and the dentist is usually surprised, but will most often inject more medication and give it time to work. So let me explain what local anesthetics are. Local anesthetics are medications that work on ion channels that help block sensation and motor function. So you're both numbing the feeling and numbing the muscle itself. That's why you'll have like a droopy face sometimes after a dental procedure. Local anesthesia helps reduce the amount of oral medication or systemic medication that you might need for the same procedure. If you can tolerate local anesthetic, you can avoid a general anesthetic in many different types of procedures. Local anesthetic is often mixed with different types of drugs, most commonly low dose of epinephrine. Epinephrine is there for a couple of reasons. One, it reduces the blood flow at the area because epinephrine is what we call a vasoconstrictor. It causes blood vessels to narrow. This both reduces bleeding at the surgical site and keeps the local anesthetic at the site that it needs to be. So it prevents the local anesthetic from diffusing into the broader area. So the dentist is going to mix up the numbing medication, the local anesthetic. There are a few classes of local anesthetics. There's quite a few different types of local anesthetics. They are usually categorized in two categories by a particular mechanism of action, and each one of them has an advantage or a disadvantage. Typically we look at the potency of the medication, how much or how little of the volume that we might need to get the desired effect. And secondly, we look at the duration of action. How long is this procedure going to last? How long do we want this patient to be numb? You might think initially you want to be numb for as long as you possibly can, but if you've had a numb mouth for an extended period of time, that's really going to get in your way. So as clinicians, we like to assess and choose the best tool for the particular job. And that's what we do with local anesthetics. How much are we going to need, and how long is the medication going to last? Now that the medication has been mixed up, it needs to be injected in the appropriate place for the medication to work. In my practice, I use local anesthetics a lot, or at least I did when I was working, both intravenously through an IV, and there's particular reasons and advantages for that, particularly in heart surgery, but most often to numb nerves that cover body parts that are going to be operated on. If you know someone who has ever had shoulder surgery, they might have woken up from their surgery with a numb shoulder because somebody like me, an anesthesiologist, injected local anesthetic around a nerve bundle in their neck that provided the nerves that caused sensation and motor function in their shoulder. In my practice, I would use an ultrasound to visualize the actual nerve bundle that was my target and inject the medication around the nerve bundle under direct visualization. This isn't always possible, and I've never seen a dentist use an ultrasound to inject local anesthetic into the mouth or the oral cavity. It is probably not practical for most tooth surgeries to do this. So what they go by is anatomy. And just like medical students, dental students spend a lot of time in the anatomy lab. And most people typically have a predictable trajectory and a predictable anatomy of their nerves and vessels. And so we use body landmarks like the corners of the jaw to assess where you're going to inject the numbing medication. They also have to take into account which tooth or teeth they're going to be working on. So that's a little bit of the background. Let's talk about where things can not necessarily go wrong, but where there can be challenges. First, the medication itself. Let's talk about the local anesthetic. Local anesthetics, like all medications, have particular type of metabolism, and local anesthetics in particular are affected by enzymes in a patient's body. Some patients are more or less sensitive to the local anesthetic. Typically, this means some people break down the drug more quickly than other people, so it wears off a little bit more quickly. Local anesthetic is also affected by the pH of the tissue into which it is injected. You, as a typical patient, do not have a lot of control over your body pH. We think about these things as physicians and clinicians when we see areas of infection or in patients who have an active infection going on. By this, I mean like sepsis. So the pH is going to affect the way that the local anesthetic works. You can drink all the alkaline water that you want. You're not really going to change the pH of your gum line on the day of your surgery, most likely. That's a pre-existing kind of not controllable scenario for your average patient. Infection is something else, and so oftentimes these anesthetics don't work as well in areas that are infected, or they metabolize differently in areas that are infected. The other medication that's often involved in these nerve blocks is epinephrine. I have met patients who swear that they are allergic to epinephrine. Epinephrine is a very strong drug, but it is very difficult to be allergic to a chemical that is circulating in your body. Epinephrine is also known as adrenaline, and it is what we use as a last resort for treating allergic reactions. Epinephrine constricts blood vessels. It increases heart rate. It increases blood pressure. In an awake patient, this can make you feel dizzy, jittery, and unwell. Most of the time, patients do not have adverse reactions to epinephrine that's mixed in with local anesthetic. But when you're not able to inject under direct visualization, and even if you are, there is the possibility of some of that epinephrine getting into the bloodstream, and you're going to feel really funny from the effects of the epinephrine. Epinephrine does wear off, but we as patients with long COVID who already have a sometimes dysregulated autonomic system where our heart rates are elevated and not regulated as well as they used to be, our blood pressure fluctuates, we might be more sensitive to the epinephrine if it gets into our bloodstream. That's the drug part. The second part is injection site. So your tooth is going to be numb if the local anesthetic was injected along the nerves. And because your dentist is not visualizing your nerves under direct guidance, they're making their best, very educated guess based on typical human anatomy. And sometimes human anatomy differs. Some people have anomalous anatomy. Some people have variance within normal. And so there are, as you can see, a few reasons why a medication like local mixed with epinephrine for a tooth procedure might metabolize more quickly based on your genetics, might cause you to feel unwell transiently because of the epinephrine, and there's a chance that you're going to need more local anesthetic if the local doesn't hang around the nerves as long as is needed. In trained hands, local anesthetic is very safe. Some people do have a true allergy to a type of local anesthetic or one class of local anesthetics. If you are one of those people, you're going to have an allergic type reaction. That includes lowered blood pressure, elevated heart rate, but also flushing and possibly a rash. You need to tell your dentist about that. You need to tell your anesthesiologist about that and try to remember the name of the numbing medicine that caused it, because it doesn't mean you're allergic to all numbing medications. It means you're allergic to a specific class of local anesthetics, and there are alternatives that we can use. There are reasons that local anesthetics don't work effectively 100% of the time. That has little to do with you being allergic to it or your body being dysregulated by long COVID. I don't know that long COVID doesn't cause an increased sensitivity or an increased metabolism of local anesthetics, but I do know there's plenty of reasons that people feel discomfort when they're having a procedure just with local anesthetic. And I hope that this explains why that could happen. I want to take this opportunity to step on my soapbox a little bit and support the notion of going to see your dentist. I know many of us, quite scared about being unmasked in a medical situation. But your dental health is really, really important. It can derail your health even if you don't have COVID or long COVID. Please take care of your teeth. Your teeth are more than just your ability to bite and eat. They can affect you systemically, and the health, having a healthy mouth may really significantly improve your quality of life. Of course, communicate with your dentist. Try to find one that you feel comfortable with, who will take adequate precautions for you, and hopefully for all of their patients. But don't, the risks of not seeing your dentist, especially when you're having an active issue in your mouth, the risks of ignoring that is not inconsequential. Now let's talk about general anesthesia. General anesthesia is a completely different type of anesthesia than local anesthetics. General anesthetics are administered through the blood and through the lungs, where they are taken up into the vascular system and into the brain. I'm not going to go through all of the ways that anesthesia sort of puts you to sleep, quote unquote, but I do want to talk about the physiologic changes that anesthesia induces and why your anesthesiologist has the number of monitors that they do and needs to be hypervigilant for every patient undergoing general anesthesia. General anesthetics reduce your blood pressure almost universally. They do that by causing vasodilation, which means dilating of the blood vessels. When the blood vessels are dilated, more blood lives or sits in your peripheral system, which means less is in your heart. The blood in your heart that's pumping determines blood flow to your brain and your blood pressure. In response to a drop in blood volume or this vasodilation, in order to maintain your blood pressure, your body's autonomic nervous system, which is the nervous system that we don't typically have control over. It does what it does. It helps your heart beat. It brings blood to your fingertips. And the vessels dilate and constrict in order to get blood throughout your body and in response to different changes in your activity. So you get general anesthetic, you're counting down from 10 and fall asleep. Your heart's blood volume drops. In order to counteract this and maintain a normal blood pressure, your body's heart rate increases. Heart rate and the blood volume work together to maintain and determine your blood pressure. So your brain and your vital organs are getting enough blood supply during this time that your blood pressure is trying to drop. So general anesthetics try to drop your blood pressure, and then your body reacts in a way to try to compensate. Here is where some of the problems arise in patients with long COVID. I suspect that a lot of the adverse events or scary events happen because of dysautonomia that many patients with long COVID experience. POTS is in the category of dysautonomia. Essentially, our body's regulatory system of maintaining blood pressure and responding accordingly is out of whack. And we see this very dramatically sometimes when we're under anesthesia and there is an immediate drop in blood volume. The body doesn't really respond in the way that it would have before. And so sometimes we see profound hypotension or low blood pressure, significant or like out of proportion increase in heart rate, and we are slow to settle down. When we think about going to sleep and waking up in anesthesia, it's like taking off or like in a plane and landing the plane. These are the times where the most changes are happening, where we have to be the most vigilant, where we're going to see some big problems. It's make or break time. And that's partly because of the response that the body has to the anesthetic drugs that it's been given. We are sensitive to drops in blood pressure. We don't have a well-regulated nervous system to help offset the drop in blood pressure. And we are sensitive to medications that we might not have before. So let me talk about histamine and histamine release under anesthesia. Many people with long COVID have more allergic symptoms than they did before. An allergic symptom, like a real anaphylactic reaction, causes, some of the same things that an anesthetic medication would. Vasodilation, increased heart rate, increased heart contractility, so your heart's pounding. It also causes swelling and rash. You can see some of this overlap then in physiology between the response to the body undergoing just low blood pressure and then something causing low blood pressure like an allergic reaction. Many patients with long COVID have MCAS, mast cell activation syndrome, in which you can think about it as like a hyperallergic state. Some medications that we administer as anesthesiologists trigger histamine release, and these medications patients with long COVID might be very sensitive to. We want to avoid histamine releasing agents. Luckily, there are many alternatives. Most of the histamine releasing medications are a little bit older, and even those that are new, we have alternatives to. So there are some pain medications that are known to release more histamine than others, so we can avoid that. There are some muscle relaxants that are known to release histamine more than another class, so we can choose wisely and appropriately for each patient. That being said, we can't avoid histamine release under anesthesia. The key to understanding anesthesia is that it is still a little bit of magic. I worked with an anesthesia technician for a long time who told me that her child, when they were quite young, was undergoing anesthesia, and she tried her best to explain going to sleep, and he called it, so are they going to give me the magic potion? And that always stuck with me because anesthesia is like a magic potion. We have many monitors currently that give us insight into what is happening moment by moment in our patient's body under anesthesia. Many of these were developed as recently as the 1980s. So they haven't been around for a very long time. And we still don't have a ticker tape, coming out of you that's telling us exactly what's going on in your body's blood vessels or even at a cellular level. So as anesthesiologists, we are persistently detectives, doing our best to integrate the information that we have from our monitors and by observing you, of course, and acting with our most educated assessments. Your anesthesiologist cannot promise that you're going to have a nice and easy and smooth process. Undergoing a surgery is a risk, and you are probably only there because the risk of avoiding surgery is much greater than the risk of getting the surgery done. That being said, it is even though it's the right decision to get that procedure, it doesn't mean it is going to be easy. And I've had surgery since being diagnosed with long COVID. Mine in particular was very uncomfortable recovery. I was very surprised. I was very confused. So we talked about the intraoperative course of anesthesia. Your anesthesiologist can choose medications that are less likely to harm you and more likely they can avoid the medications that are most likely to harm you. They can, to offset the drop in blood volume, give you a fluid load before giving you the anesthetic medications and keeping you ultra hydrated during the anesthetic. This sometimes helps the anesthesiologist avoid having to give additional medications to help your body's blood pressure come up by giving enough volume. A lot of times that is effective. But even that being said, it's not appropriate for everybody, especially those who have some weakness in their heart or in their livers. Patients with long COVID are sensitive to medications they were not previously sensitive to. It makes me think that our metabolism, even at like an enzymatic level, has been, warped. And so what I talk to my anesthesiologist about is that I'm quite sensitive to narcotics now. I will get ultra sedated. I've always been a lightweight, but I am more sensitive to medications now. And so I'll just ask for just start slow and keep in mind that I'm very sensitive to any medications that you might give me. That is a vague request, though. And a lot of anesthesia is magic. Like I said, it is an art form. Dosing for medications were based on research studies, many of which are very, very old, most of which were probably exclusively done on one, strict demographic of men between a certain age range. And the patients were probably healthy. So your anesthesiologist, like I said, is constantly being a detective and using their best assessment to give the dose that is just right for you. but we don't have a way of knowing what is just right until we get the results back, meaning how we see how you respond to it. Once you've had your surgery or your procedure, you may have had sedation, in which you had a few IV medications to help take the edge off and make you feel like you were asleep, or make the memory of the procedure really fuzzy. Or you might have had general anesthesia, in which the anesthesiologist had to put a breathing tube in your mouth and help you breathe on a machine and administer a lot more medications to keep you asleep and safe during the surgery. Now your procedure is done and you're in the recovery room. Whether you had sedation or you had general anesthesia, there is a chance that you're going to feel a little confused, really hazy mentally, and uncomfortable. I found that I was very slow to wake up, and anytime I got pain medication, it put me back and made me even more sedated. I was very sensitive to input, so noises felt really loud. Lights there, the recovery room is a noisy place. There's a lot of people, there's a lot of monitors, and everything has to be audible because it's a way for your care team to recognize that you're safe at all times. I benefited from an eye mask. I would have benefited from earplugs if they were available to me. I would have benefited from a much more quiet space. But there are significant limitations when you're having surgery in a hospital. It might be a little bit more of a smaller, quaint setting if you're in a place like a standing surgery center or in a boutique operating room or surgery center where there's only one or two operating rooms. So if you're in the busier centers, it's going to be a louder recovery period, and there's going to be less quiet. Recovery took quite a while for me, and I ended up coming home. I wanted to be discharged, even though I had a very long recovery room stay, and I was still feeling very unwell. I did that for several reasons. One, I was awake enough. I know I'm not my own doctor, but I had confidence that I could take care of myself and recognize what was worrisome, more than someone without a medical background. But I don't recommend this to anybody. I had someone with me who was going to be with me, my husband. I knew where I would go if trouble arose. I have a hospital that's very close by to where I live. And ultimately, I knew that I needed a quiet, dark space to be still in while these medications worked their way through my system. I had a pretty significant surgery, and so there is a combination between the effects of the medications to keep you asleep for surgery and the very real stress response that happens from somebody performing surgery on you. There is swelling, there is edema, the body has been assaulted, the body is doing everything that it can to help heal that assault. And that is itself is not a small thing, especially when you are already dealing with limitations of long COVID. I want to make it clear here before I forget to mention it that I am not at a high risk factor for having a bad respiratory event. I don't have sleep apnea. I was clear-headed when I came home, And so I wasn't at risk of falling asleep and then not waking up. Everybody has to remember that you still have your pre-existing conditions in addition to your long COVID symptoms. And we have to keep all of those things in mind when we're approaching your surgery and your recovery. The message I want to make is that surgery is not a small deal. Sometimes it is your best chance to solve a specific problem. And it can be a difficult recovery, even when your doctors take every precaution for you. In the end, I am very, very happy that I got the surgery that I did. It significantly benefited me and my symptoms, even though it was a tremendously difficult recovery period. That being said, it's not guaranteed that you're going to have a terrible recovery period. It depends on your body at the day, the doctors who are working with you, all of the healthcare team, but also what type of surgery you're having, what problems it has already caused, how painful that type of surgery is typically, and the things that your doctors do to help offset the need for more oral drugs or IV medications. Like I said, like a nerve block for a shoulder surgery is going to help keep you off narcotics for a day, at least. A lot of my patients had a very comfortable arm for 48 hours and didn't need any medication until that point. You're going to undergo, this is a pro-inflammatory process. Surgery is a pro-inflammatory process. So we do it only when we need to do it. So be very clear in your decision making. Your goals of care have your why in mind. I am doing this because I anticipate these obstacles. These are some ways I'm hoping to offset some of these obstacles or navigate around some of these obstacles. And after a certain period of time, I think I'm doing this because I think I'm going to benefit from it in the long run. And that's really the best you can do. We can't avoid discomfort, especially when we're in long COVID, but I don't want you to be terrified of surgery or a dental procedure or out and out avoid a procedure that you clearly need because you're worried about the anesthesia part of it all. There's more to it than just the medications. There is no guarantee that it's going to be perfect, but it's not guaranteed that it's going to be terrible. There's a very good chance you're going to have a very decent recovery, and there are things that your care team can do to optimize the chances of you having a very speedy and successful recovery. I hope that was a helpful explanation of anesthesia. Send me feedback. My email is longcovidmd@gmail.com. Follow me on Twitter at Dr_Zeest. That's DOCTOR_ZEEST. And stay tuned for some new things. So this is the last episode of season 1 of Long COVID MD podcast. I am working on season 2. It's going to be bigger, bolder, more informative. I've gotten some good practice recording, and I want to offer you guys validated information about your bodies so that you can make educated choices for your care. I cannot promise you that I have a treatment protocol for long COVID or a cure, but I think if you are armed with knowledge about all of your options and you have heard information from reliable sources, then you will be more empowered and less confused in navigating this already confusing healthcare system. So there is going to be another pretty long break while I get season 2 up and running. We're going to have interviews with experts in various fields. I'm going to be giving you some tutorials and explanations that I hope will enlighten you and things that you can take to your own doctor to get personalized care. And we'll get to know each other more. So follow, leave a good review, follow me on Twitter, email me at longcovidmd@gmail.com. Thank you for listening to the last episode of Season 1 of the Long COVID MD podcast. I'm your host, Dr. Zeest Khan. I hope you're feeling well today. Good luck with any surgeries or dental procedures you might be having in the future. And until next time, bye for now.